from the American Academy of Pediatrics.
Pediatrics is all about prevention. Wear helmets, use car seats, apply sunscreen.
Now the AAP has guidance about preventing excessive noise.
I think we need to pay more attention to noise as an environmental hazard. It hurts. Too much noise, too loud, too often can hurt hearing.
But first, it's December, and that means it's time for our monthly research roundup.
I think it's a great example of a shift to upstream, that if you can intervene earlier when children are less severely affected, you can really alter the course and improve healthcare.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at all the latest from the journal Pediatrics.
David, 'tis the holiday season. How did your Thanksgiving go?
Well, we had kids all over the place on the actual day, so we celebrated a few days late and got all 5 kids under one roof again, which rarely happens anymore. The upside, we're still eating leftovers.
Well, I am a big tryptophan fanatic these days. Anything that helps me get sleep as things get a little more uncomfortable toward the end of pregnancy. But I'm still really looking forward to December. We celebrate both Christmas and Hanukkah, so there's a lot of light in the house this month for us.
Well, since this holiday season is starting to burn bright, let's shed some of that light on the most influential articles in the December edition of Pediatrics.
Today, our gift to you is having on with us the Deputy Editor of Pediatrics, Dr. Alex Kemper.
He's here for First Up to give us a rundown on all of the articles we should read to finish our year with cheer. Alex, welcome back.
Glad to be here. Happy holidays.
Thank you.
Hard to believe, the end of the year.
I know.
Right? Time flies. So let's not waste any time today. I work in safety net settings, both outpatient and inpatient, in rural and urban locations, and I noticed that in both areas, a tragically high number of my patients have an incarcerated parent. I think a lot of people would imagine that parental incarceration rates are more of an urban issue, but would those people be surprised by the data? And what are the implications for my patients?
David, I think most people don't realize the magnitude of the problem in the United States, the high proportion of individuals who are incarcerated. Did you know that in the mid-year 2021, there were 2 million people incarcerated in the United States? And of course, many of them are parents. So this month, we're releasing a paper on rates of parental incarceration in the United States from 2016 to 2021. This paper was led by Dr. Luke Muttner, who is at the University of Minnesota, but had many co-authors. This paper looked at data from the 2016 to 2021 National Survey of Children's Health. So this is a nationally representative study. And what it found was that the rates of parental incarceration in rural areas was actually higher than urban and suburban areas. So in rural areas, about 12% of children had ever experienced parental incarceration, compared to about 8% in urban areas and about 6% in suburban areas. So that to me was really surprising. When I think about rates of incarceration, I think about the mass incarceration that began about 50 years ago. But what I didn't realize, and this paper does a good job of explaining, is that there are structural inequities in rural areas that can end up increasing the rates of parental incarceration in rural areas. Things like staff to help move cases through and that sort of thing. So again, we know that parental incarceration is an important adverse childhood event, and that there are many things that we could do as pediatricians to help support children who have a parent who's incarcerated. But I think this paper also points out an important advocacy role that we can play as pediatricians in making sure that not only the children are receiving high quality care, but that local communities have the support to be able to address issues of parental incarceration and move cases through as appropriate.
Thank you for that, Alex. And speaking of communities, so far the influenza season where I live in Philadelphia hasn't been bad yet, but I do still have one child, Simon, under 5, and I worry especially about him getting the flu this year, even though our family is all vaccinated. Of course, if he does get it, there's always oseltamivir or Tamiflu we can use. What have we learned about who is getting antiviral therapy when they get influenza and who is not?
I think it's so important that we're talking about influenza right now because I feel like flu is kind of getting second billing given all the attention that's being played appropriately on COVID and also all the exciting stuff that's going on around RSV, which I know we've talked about in the past. But it's important to realize that flu is a major cause of morbidity and mortality in this country. And so before we talk about the antivirals, I just feel like it's incumbent on me to remind everyone, go get a flu shot, right? That's one of the best things that we can all do to protect ourselves and protect others against influenza. So this month, we're releasing a study that looks at trends in outpatient influenza antiviral use. It was led by Dr. James Antun, who's at Vanderbilt University. And this paper looked at private insurance claims between 2010 and 2019, and it carries with it an important reminder for us all. And that is we should really think about antiviral prescriptions. For most of our patients, it's going to be Tamiflu or oseltamivir, which is the oral antiviral that's approved for all age groups. This study found that depending upon the population that you are looking at, the age and that kind of thing, somewhere between a half and 2/3 of the time was an antiviral prescription filled within 48 hours of a diagnosis for children and adolescents. But even more concerning, less than 40% of the time were antivirals used for children under 2 who were at high risk of having influenza complications. This study found a lot of variability in terms of who was getting it. But again, it's just such an important reminder. We know that these antivirals, if they're going to be effective, have to be given within the first 48 hours of the infection developing. We think that this message is so important that we had a commentary that was written by Dr. Pia Panaraj at the University of California, San Diego, to really underscore the important issues. Dr. Panaraj reminds us that, again, the flu can lead to significant illness, and it's critical for us to remember that half of the pediatric influenza deaths occur in children who are otherwise healthy. Dr. Panaraj also reminds us that there's really many large studies showing that antivirals are both safe and effective. So I hope that this study and the accompanying commentary reminds everyone of the benefits of antiviral use and the importance of thinking about them and prescribing them so that children can get them within the window when they're going to be effective. Of course, and I know I sound like a broken record, don't forget to vaccinate.
That is the best advice we can get all holiday season. I mean, it's after Black Friday already, so this is the best thing we can get.
It's the main point I want to make.
Yeah, okay. Good point. Now you're just needling us.
Yeah, exactly. Just had to take a jab at that.
It has to end. So, Alex, earlier I mentioned working in a federally qualified health center here in Wilmington, and one aspect that I love about it is that we use a single component, highly integrated, team-based model of care that makes it incredibly easy for me to access same-day services when I identify a mental health need in a patient I'm seeing. Has anyone studied how these models compare to other, less integrated pediatric primary care settings? And if someone has, we'd love to talk with that person.
Who could that person be? So I wonder, this month we're releasing an article on utilization of behavioral health care using integrated psychologists in primary care that was led by my colleague and friend, Dr. Cody Hustetler, here at Nationwide Children's Hospital. I'm a co-author of it. These were done in the clinics that I help oversee. I'm a little sheepish because this is the first time on the podcast where I've talked about a paper that I was involved with. But I think that the lessons here
That's
are
not true, Alex, because
important.
hyperbilirubinemia.
Oh, hyperbilirubinemia. How can I forget
Indeed.
about
I
hyperbilirubinemia?
can't let you
Such
go
a
on that one.
coincidence.
I would say all the listeners are going to think whenever I publish something, I talk about it on the podcast. And let me just say, in case anyone's wondering, when articles that I'm a co-author of show up at the journal, I'm recused from the whole decision-making process. So I don't want you to think I'm like slipping in anything.
That is good to know.
Good to know.
Thank you,
Good to know. But this study looked at integrated psychologists. So in our clinic, we have psychologists who have maybe 10 or 20% of their visits filled. And the rest of the time, they are there to help out when we are seeing patients. And they can really come in for anything. It could range from helping patients who have trouble swallowing pills or helping parents whose children have problems with sleep to coming in when there's concerns of significant depression, suicide risk, anxiety, really any reason. And we know that the rates of behavioral health problems have only increased, especially with the pandemic. So this was a study that assessed the role of integrated psychologists. And I want to make a distinction between integrated psychologists and co-located psychologists. So co-located psychologists are psychologists who may work in a primary care clinic, but I think of them as parallel train tracks. They kind of have their own practice within the primary care center. Integrated psychologists are really part of our care team, and they're involved with helping all of our patients and families. So we were able to take advantage of a natural experiment, the time period when we were rolling out these integrated psychologists into our practice. So we had a control group. And not surprisingly, if you have an integrated psychologist, there's basically no wait to see a psychologist when you need them. But what's interesting, too, is it also speeds up referral to specialty care when children or teens need to see a specialist for more complex ongoing care. And there was also some concern that having an integrated psychologist might actually end up leading to more referrals for behavioral health services, but it actually was associated with about a 25% drop. So from about 5% to somewhere between 3 to 4% of our patients were referred on to further subspecialty behavioral health care. And I think it's a great example of a shift to upstream, that if you can intervene earlier when children are less severely affected, you can really alter the course and improve healthcare. I can't say enough great things about how it is to have an integrated psychologist. I know that we're unique in our ability to be able to do this because we have an accountable care organization. We're fully capitated and we're able to reinvest into preventive services like this. I think future work is going to need to be done to figure out how we can help other practices have an integrated psychology model. And it's clear that there's not one size that's going to fit all practices, but I hope that the listeners recognize the difference between integrated psychologists and co-located psychologists and what an incredible benefit it is to have an integrated psychologist.
And this is incredible work. So thanks for sharing your work with us on the podcast, Alex.
Super excited. Thank you.
And Alex, you've given the podcast so much in 2023. So David and I felt like we really needed to give you something to show our appreciation for you this
I love
year.
getting things.
No, wait till you get it. You may not. You may want to regift this one.
But David, are you ready?
I guess.
Okay. Oh, the weather outside is frightful, but our podcasts are so delightful. And since you've no place to go, tape the show, tape the show, tape the show.
It doesn't show signs of stopping. Articles keep on dropping. Keep your voice clear and slow. Tape the show, tape the show, tape the show.
Woo! Lewis is going to be very jealous.
Practice, we could have harmonized with practice, but Alex, I don't know if you can tell, we did not practice.
We did not.
I thought that was great.
We made this just for you on the spot.
Let's just say no other present is going to compare.
Yeah, you can listen to that over and over again.
Anyway.
Yes.
Yeah, I hear it's going to trend on Spotify.
Well, we want to thank you so much, and we want to thank everyone who's listening this holiday season and wish everyone a wonderful December. So, Alex, hope you have a wonderful rest of your holiday season.
Yeah, happy holidays and happy New Year.
To read all the papers we reviewed today and more, join us on aap.org/podcast.
Coming up, we'll talk about different types of noise and how they can be perceived as pollution.
David, I don't think I've ever really talked in depth with you about my neonatal fellowship research. If I was going to become a physician scientist, it would have been studying how intrauterine sounds affected nervous system development in premature infants.
Oh, that is so cool. You know, we've been friends for years, and I've never really heard about this work. What did you look at to study in these infants?
Well, compared with other areas of medicine, neonatal intensive care units spend a lot of time thinking about how sound affects development. And even with this focus, we often exceed recommended sound levels in delivering our care. And I was passionate for a time about trying to find developmentally appropriate sounds to either replace or mask the NICU environment for better growth and development of infants, particularly, again, premature infants.
Well, if you're still passionate about this work, the AAP recently released a new policy statement and technical report on preventing excessive noise exposure in infants, children, and adolescents. And today, we get to talk with the lead author, Dr. Sophie Balk, to hear more about the effects of sound and noise.
Dr. Balk is a professor of pediatrics and general pediatrician at a federally qualified health center and is affiliated with the Children's Hospital at Montefiore and Albert Einstein College of Medicine. Much of her career has been spent focusing on pediatric environmental health. Dr. Balk, welcome to the show.
Thank you so much. It's great to be here. And it's great to hear about your research focused on little NICU babies, but there's so much more.
Oh, can't wait to hear.
I am really glad you brought that up because while Joanna is probably better versed in sound research than I am, can we start with some definitions, like how we measure sound waves?
So sound has several characteristics. It has intensity or loudness, and this is measured in decibels or pascals. It has frequency. This is measured in hertz, and it has periodicity and duration. One important thing about measuring sound intensity or loudness is to know that the decibel scale is not linear. It's logarithmic. So 20 decibels is 10 times higher than 10 decibels, and 30 decibels is 100 times higher than 10 decibels, and so forth.
And the policy statement talks about different types of noise. Can you go over them?
Yeah, so there's occupational noise. This is noise experienced in the workplace. And we've known about the effects on workers of occupational noise for centuries. Then there's environmental noise. So that's indoors and outdoors. So outdoor sources include traffic noise, airplanes, airports, railways, and wind farms. Then indoor sources are things like appliances, infant sleep machines, TVs, and then the radio, things like that. So you have indoor and outdoor sources of environmental noise. This type of noise is called noise pollution, and it's less likely to cause hearing problems than occupational noise or the other form of noise, recreational noise, but it has other health effects. And then there's recreational noise, and that's also known as leisure noise. So we're talking music played through our headphones and our earbuds. We're talking going to celebratory events, weddings, bar mitzvahs, quinceañeras. We're talking going to restaurants that can be noisy. So that's recreational noise.
I want to get into that. We've talked about how noise can cause harm to hearing, but you've mentioned some other concerns. How else can noise negatively affect children?
It really depends. And it's a pretty complicated answer. There are effects on hearing at certain noise levels. So a very intense noise can damage your hearing instantly. So if you're near a blast or like gunfire and explosion, if you're close to that, that can immediately hurt your hearing. And what is hurt is the hair cells of the cochlea are very sensitive to noise, and they can be immediately damaged. Most hearing loss occurs as a cumulative exposure, less loud noises over time.
And Sophie, you heard a little bit about my interest in sound, given that I work in the NICU. What made you so interested in this topic as someone with a focus on environmental health?
Well, it's pretty personal to me. About 18 years ago, I became interested in dancing. I became a social dancer. I entered the world of West Coast swing, which is a great world with great music, great exercise, lots of nice people. And I took a lot of classes, and I went to a lot of dance events during the week and on weekends. And although it was a lot of fun, it tended to be very loud. Sometimes we would ask the organizers to turn down the sound, and sometimes they would, and sometimes they wouldn't. But over time, I developed tinnitus, which is an injury that can happen from noise, which is buzzing in the ears that is not from an outside noise. It's kind of an inside noise, and it's an injury caused by noise. And I developed some hearing loss. And I began to wonder, why hadn't I paid more attention to this? I've been in the environmental health world for a long time, talked about sun exposure, lead, mercury, all these environmental hazards. I wondered why I didn't know more about noise, started to study this, and really wondered about the effects on kids. Kids, teenagers, even young kids are exposed to lots of noise. A lot of kids use headphones. Began to wonder what the effects were on them. And this was the start of the policy statement and the technical report.
We know children are unique. Do they have anatomic or neurologic features that might make them more susceptible to changes in hearing when they're exposed to sound and noise?
Yeah, that's a great question. There are many reasons that we're concerned about children's unique exposures to noise. So we know from studies in animals that young animals are more susceptible to noise effects than older or adult animals. There are differences in behavior and development. So young children, infants, rely on adults to remove them from noisy situations. Children sleep longer, so they may be more affected by environmental noise, like traffic and railways and airplanes. Teens may not realize that they're susceptible to the effects of their exposures from going to dances or concerts or listening to music at loud volumes through their earphones, their headphones or earbuds. Those are some of the reasons that kids are more susceptible. Also, we talk about shelf life. Kids have long lives ahead of them to experience the effects of repeated and cumulative exposures. Also, kids are learning. So if they're in a situation where there's a lot of background noise, environmental noise, they may not be able to learn as well as they would in a quiet environment.
I want to get into that. We've talked about how noise can cause harm to hearing, but you've mentioned some other concerns. How else can noise negatively affect children?
We know that environmental noise has physiologic effects, and there's good evidence to show that certain levels of environmental noise can increase your rate of heart attacks, ischemic heart disease in adults. There's also some evidence in children showing that environmental noise, traffic, noise from airplanes, can raise your blood pressure. So there are physiologic effects. There are also psychological effects. We know that too much noise can create annoyance. You have no control over, let's say, your neighbor blasting music, or if you live in an apartment building, people walking around at night causes annoyance. This causes a stress response. Sleep disturbance also. Too much noise can interfere with your sleep, and that has physiologic effects also. We also know that background noise can affect learning. Even kids with normal hearing, if there's enough background noise, again, from traffic or airplanes, can affect learning. And there are lots of studies about that.
I have to confess that when I'm in clinic, I don't usually spend a lot of time counseling on the harms of noise exposure, but now I'm curious. What noise exposure should I consider counseling on during health maintenance visits?
Well, there are quite a few. The one that I tend to focus on is personal listening devices, headphones, and earbuds. A lot of teenagers will listen to music. It's a very, music is a source of joy and pleasure and relaxation for so many people. But if you listen at too loud a volume for too long a time, it can affect your hearing. So when I'm in the office with a teenager and, I ask what they do for fun, and they say I listen to music, that's an opportunity to talk about turning the volume down. It can also be discussed, and I often do this when I'm examining their ears. So that's like a major place that we can deliver a message about protecting hearing. For infants, one source of noise is white noise machines, infant sleep machines. These are pretty popular. They're meant to be played pretty loud, louder than the baby's crying. But there's a study that shows that some sleep machines can be so loud that they could potentially injure a child's hearing. So, if you're asking about baby sleep and what parents do to promote sleep and they're using a sleep machine, you can counsel them. If they're going to use it, play it at the lowest volume that you can for the shortest duration that you can. And also, don't put it right near the baby. Place it as far away from the baby as possible. If kids are taking a trip, parents often use headphones. If they're kids are taking a car trip or they're going to be riding in an airplane, the noise level in an airplane can be pretty loud. So noise-canceling headphones are important because if you don't have noise cancellation, kids might turn up the volume to block out the background noise. So a noise-canceling headphone is often important.
I love those tips you were putting in about how to use these different things like infant sound machines and noise-canceling headphones. Are there any other tools that pediatricians can recommend to families to help offset harmful noises when they're with their children?
Putting hearing health on the agenda, if it's not already on your agenda as a clinician, I think is important. Getting kids to respect their hearing, protect their hearing. We do all sorts of preventive things. We tell people to prevent excessive sun exposure. Put on your clothing, put on your hat, put on your sunscreen when you go outside. We tell you to put on your seatbelt. Make sure the baby's in the car seat. I think it would be a good idea to try to get parents and kids to put hearing health on their agenda. If you're going out, if you're going to an event that you know is going to be noisy, make sure you have hearing protection. And we should teach our kids to think about hearing protection. Now, if you're a parent and you're going to go to a sporting event, if you're going to go to a wedding, those tend to be really, really noisy. Make sure if you're bringing your infant, make sure they have some hearing protection. Get some protective earmuffs for your baby. And if it's too loud, because we know that children are often more susceptible, or we're worried about their being more susceptible to noise and getting noise-induced hearing loss, you can leave the event. If you're at a noisy event where there's music, stay away from the speakers. Things like that.
Is there an equity aspect to this issue, or are certain populations more prone to harmful exposures to noise?
There's definitely an equity issue. People in minority communities and historically marginalized communities are more exposed to environmental noise, being located near the railroad or near the highway. There's also a different kind of a disparity issue. People with existing hearing loss, adults or children, can't fully participate in certain events. For example, if you have hearing loss and there's a noisy restaurant, you really can't go there because you can't hear. It makes your tinnitus worse. It makes your hyperacusis worse. And hyperacusis is a condition where you react negatively to sounds that wouldn't disturb a person with normal hearing. So you go into a restaurant and you can't be there. You go into a dance, you can't be there. It's just exacerbating your hearing problems. So these disorders turn into disabilities for people with existing hearing loss. That's a different kind of disparity issue.
And are there state or federal routes of advocacy pediatricians can take if they're worried about the harmful effects of sound in their patients?
There are many organizations that are focused on this. The Centers for Disease Control has information about this. I'd like to see more done. Personally, I'd like much more attention to be paid to this at the federal level. There are occupational standards for noise exposure in the workplace, but there are no federal guidelines in the United States regarding recreational noise or environmental noise. There's a lot more done in Europe. There are many, the Europeans, the World Health Organization, have done a lot of work on environmental noise and recreational noise, and they have standards for this. So we can work with various organizations. But what I'd like to see personally is a call to action about hearing health and noise exposure. There was a call to action about skin cancer prevention in 2014 that came out of the Surgeon General's office. That's what I'd personally like to see, is a call to action to highlight noise as a problem for hearing health and for many other aspects of health. But pediatricians can, work at local levels for noise ordinances, leaf blowers, other things that environmental noise that disturb people, including children.
Dr. Balk, we could listen to your voice all day. We love your frequency and your decibel levels. But we can't keep you in the studio all day with these headphones on. So if you had one last takeaway, what would it be?
I think we need to pay more attention to noise as an environmental hazard. It hurts. Too much noise, too loud, too often can hurt hearing. And noise-induced hearing loss is preventable. That's a very major takeaway. We can prevent noise-induced hearing loss.
Dr. Sophie Balk, thank you so much for joining us today.
Thank you so much. Thanks for giving me the opportunity to talk about this really important issue for kids and for adults.
It is such an important public health issue, and to read the new policy statement and technical report on preventing excessive noise exposure in infants, children, and adolescents, go to aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Oh, well, Joanna, you have the great fortune of seeing your kids every day, at least when you're not at the hospital. For me, now it's a special occasion, but fortunately, I'm right in that period that I love, where we just had all 5 kids under one roof. For Thanksgiving, we got to celebrate 3 birthdays for all 3 of my kids. They're born within 13 days of each other on the calendar. So we did a big celebration, and it was madness, as it always is. And they're coming back shortly for winter break, so I do not have to be without them for long. And I got to say, the older they get, the more I enjoy their company. So what's going on with you?
I have to make my say about my kids now, too, because I have to relish that they're so young that they have to spend all this time with me. But mine is around the fact that we are getting ready for the baby, kind of like preparing the house and getting things ready. And I've been really making an effort to try to involve the kids so they feel like it's their baby too and not just mommy and daddy's baby. Mm-hmm. And they got so excited just sorting her clothes the other day. And just being like, oh my gosh, the little newborn ones. They're very cute. So we're all looking forward to a new edition this winter.
That is the sweetest. Wow. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk to pediatric royalty.
We'll bring you a Pathways to Pediatrics with Haley Nelson, who holds the titles of Dr. America and Dr. World. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.